One, please start, sir. We are live.
Okay, thank you. Yeah, so can you mute yourself first? Technical. Yeah, okay, thank you. So very good evening, God respected doctors. I am Dr. Kunal Javeri from Zydus Medical Team. And once again, I welcome each one of you for one of the scientific discussion. And today what we are going to discuss that how to manage the dyslipidemia. But most importantly is that when we are using a statins, and the statins are considered as a first line for primary and secondary prevention. But still the data is showing that there are many incidences are there where you have uncontrolled LDLc. So how to manage this uncontrolled LDLc with the newer options? And now we have a very newer molecule with a unique mechanism of action, that is a Bempedoic acid. And to elaborate on that, we have a very senior cardiologist, Dr. Chander Ratnam Rawat, who is a very senior cardiologist from Agra, and who is working as a consultant cardiology, having a more than 25 years of experience, who has experience in Ram Manohar RML Hospital in New Delhi, and currently is associated as a managing director at Rawat Medicare Limited, and also associated various hospitals of Agra, and who is a visiting faculty at Medanta Hospital, as well as the Fortis Hospital and Asian Institute of Medical Science from Faridabad, who is the first doctor of Agra joined to start, who started echocardiography around the late 90s, and is the founder president of Jeevan Rekha, an NGO, which is devoted to charitable and social service in the field of cardiology since 1992, an executive member of UP SCI. So with this, once again, we welcome Dr. R Rawat, sir. And sir, without taking much ado, I hand over the session to you to start the scientific proceeding side. Thank you, sir. Thank you.
Thank you very much, Mr. Kunal Javeri and your support team of Vinay More and Mr. Priyank Jain, who has helped me connect with you on this Zoom meet today evening. I also take this opportunity to thank Zydus for giving me this opportunity, this valuable time to present a new molecule, to introduce a new molecule, Bempedoic acid. And I'm really very excited about this molecule. So once again, thanks to Zydus team and the support staff for having given me this opportunity to come before you and present my views and present some data on Bempedoic acid in the uncontrolled LDLc. This is a concept unlocking and unleashing of the efficacy of Bempedoic acid. So dyslipidemia is always a major concern for cardiovascular events. We all know this. More the dyslipidemia and more the incidence of cardiovascular events, whether it is primary prevention or secondary prevention, it is dyslipidemia which is a cause for concern. In this study, which is approximately 15,152 patients were enrolled and 14,820 controls in 52 countries were taken, and the population attributable risk was adjusted for all the risk factors. And we can see the PAR for smoking as 36%. When the patients are using less of fruits and veggies, then it is 14%. When they don't exercise, it is 12. Excess use of alcohol is 7. Hypertension raises the risk factor by 18%. Diabetes 10. So just 3 folds. Just compare the data of smoking and diabetes. Smoking is 36 PAR and diabetes is only 10. Then abdominal obesity is 20. Psychosocial parameters, psychosocial responsibilities and tensions in the atmosphere, they are 33%. So smoking is, as a risk, is nearly equal to psychosocial problems. And then look at the lipids. This causes the most population attributable risk. It is 50%. If the lipids are raised, then the concern for cardiovascular events is highest. The second highest is for smoking. The third is 33% is psychosocial, then abdominal obesity, then hypertension, fruits, vegetables, exercise, alcohol, and diabetes come later on. Now, CVD primary prevention trials. We have come to know that lipids are very important, whether it is primary prevention or secondary prevention. How do you control the lipids? So we have several trials which have shown that statins are the drug of choice. These are the list of trials and primary prevention trials. The AFCAPs, in which approximately 6,605 elderly patients, in which more than 65 years, 21%, the average age was 45 to 73, and lovastatin was used, and the mean follow-up was 5.2. There was a 37% reduction in non-fatal myocardial infarction, unstable angina, and sudden death. 37%. Then we have the All Heart, which did not show any significant reduction, which is the only study which doesn't show any significant reduction. And pravastatin was used as 40 milligram in approximately 10,000 patients. The rest all, the Ascot, LLA, in 10,305 patients, where 64% of the population was more than 60 years. Atorvastatin 10 milligram was used, and the mean follow-up was 3.3 years. And there was 36% reduction in non-fatal MI and coronary deaths. In the CARD study, 2,838 patients, 40% more than 65 years. Atorvastatin, age range between 40 and 75, and atorvastatin 10 milligram. And we see that there was a 37% reduction in fatal as well as non-fatal MI, coronary deaths, unstable angina, and revascularization. In the MEGA trial, 7,832 patients with 70% more than 55 years, age range between 40 and 70, pravastatin 10 to 20 milligram, and mean follow-up of 5 years. There was a 31% reduction in coronary events, 32% reduction in total mortality, and 44% reduction in all-cause mortality. The CHS study, where 1,914 patients were studied, and all of them were more than 65 years, and statins were used, and for mean follow-up was 7.3, and there was a 56% reduction in cardiovascular disease. The Prosperous trial, 5,804 patients were followed up for 3.2 years, and pravastatin was used. Here, there was a 15% reduction in coronary death, non-fatal MI, and stroke as compared to all our trial with pravastatin, which did not show significant reduction. Here, it has shown a 15% reduction in coronary deaths, non-fatal MI, and stroke. Then we have the famous Jupiter trial, 17,802 patients, 32% more than 70 years, and 60 to 71 was the age range. Statin use was rosuvastatin 20 milligram, and the mean follow-up was 1.9. 44% reduction in non-fatal MI, cerebrovascular event, revascularization, coronary death, and unstable angina. Very robust reduction. The NNT number and the NNT numbers signify for number needed to treat, and NS is non-significant. So these are the trials which all show that primary prevention is important and statins are the drug of choice. Now for the secondary prevention trials, there also we have seen that there are statins. So whether it is primary or it is secondary, it is the statins which come to our mind. And all these trials which I have shown for primary prevention, there are several trials as well for the secondary prevention, like the Forest trial, in which simvastatin 20 milligram was used for a median of 5.4 years. And the eligibility criteria was 35 to 70 years, prior angina, EMI, fasting, total cholesterol 5.5 to 8 millimoles per liter. And the percentage change in LDL that was seen was approximately 35%. There was a relative risk reduction, RRR mortality and MI of 30% and 27%. Then in the lipid trial, pravastatin 40 milligram was used for 6.1 years. And the key eligibility criteria was 31 to 75 years, prior AMI, unstable angina, fasting total cholesterol 4 to 7 millimoles per liter, and the change in LDL was 25%. So there was a 25% reduction in the total cholesterol values and the LDLc values. The risk reduction was to the tune of 22%. A relative risk reduction, and mortality and MI was 29% reduction. The CARE study, again, pravastatin was used 40 milligram for 5-year median period, age group 21 to 75 years, prior AMI, fasting LDL raised, cholesterol 3 to 4.5, and the change in LDL was seen to be less, reduction of 28%, and the RRR relative risk reduction was 9%, and mortality and MI was reduced to the tune of 25%. Miracle study was carried out with atorvastatin 80 milligram for 16 weeks median, and the age group was 18 to 77 years. ACS screening cholesterol was less than 7, and the change in LDL was 52%. The relative risk reduction was 6%, and mortality and MI was reduced to the tune of 10%. The LIPS trial was with fluvastatin 80 milligram for 3.9 years, 18 to 80 years after percutaneous intervention, screening cholesterol 3.5 to 7, and a change in LDLc was to the tune of 27%. The relative risk reduction was 31% and 19% reduction in mortality and MI. The PROSPER trial was with pravastatin, which also showed a reduction of 3% relative risk, and mortality and MI was reduced to the tune of 14%. PROVE IT and TIMI 22, atorvastatin 80 versus pravastatin 40 for 2 years. And atorva, there was a reduction of 42% in LDLc, and with prava it was 10%. And the relative risk reduction were 28% and 13% respectively. TNT trial showed atorvastatin 80 milligram and atorvastatin 10 milligram versus 10 milligram for 4 to 9 years. And 80 milligram, there was a LDLc reduction of 21%. Atorva 20 milligram, there was no change. And the relative risk reduction was nearly none with the 10 milligram, and then it was 22% with 80 milligram of this thing. Then we have the ideal trial where atorvastatin 80 milligram versus simvastatin 20 milligram for 4.8 years, and 18 to 80 years was the age group. Prior AMI was the eligibility criteria, and with atorva there was a 34% reduction in LDLc, and simvastatin there was 17% reduction, and the mortality rate, the relative risk reduction was 2%, and mortality and MI was reduced to the tune of 13 to 15% as compared to 17% and 2 to 29%. Now, management of dyslipidemia is at most on priority. We can understand this. If you are able to control the dyslipidemia part, then you are able to control the cardiovascular morbidity and mortality. And statins are the first line of therapy. But what is the catch point? And what are the concerns with statin? Concern number one is, do all the statin users achieve LDLc goals as per guideline recommendation? You're giving statin, well, good. But do you achieve the LDLc goal as per the guidelines? That's concern number one. And concern number two is, how do you achieve the LDLc target after maximum tolerated dose of statin? So, number one, when you're giving statins, you have to find out whether the goal is achieved. And if the goal is not achieved, then how will you achieve the goal after giving the maximum tolerated dose of statin? There are a few patients. There is a group of patients whom we give the total dose, the total tolerated maximum dose of statin, get the LDLc values are above target values. What are we going to do for them? So let's take the concern number 1. Do all statin users achieve LDLC goal as per guideline recommendations? This is this. LDLC, with LDLC, we say lower is better and lower for longer. As long as you have a lower value of LDLC, it is said to be better. There is a relative risk reduction per 1 millimole reduction in LDLC, 23% relative risk reduction is seen. The weighted group between group difference in achieved LDLC levels and millimoles as compared with fibrates, acetamib, niacins, diet, statins, bile acid sequestrants, ileal bypass, and recently PCSK9 inhibitors. We have these trials in front of us. Now, comparison of LDLC targets. What were the targets by the European Society of Cardiology in 2016 versus the targets which have been fixed in 2019 after a period of 3 years? As the CV risk increases, there is a need to reduce more LDLC values. And we have seen that over the years, as we progress, the CV risk has been increasing, and therefore we have been reducing the LDLC targets. Risk category, low risk. If the patient is in low risk, then the ECS 2016 LDLC target was 115, and today also it is 115 milligram per deciliter. If the patient is a moderate risk patient, then the LDLC target 2016 was 115, less than 115, and today it is less than 100 milligram per deciliter. A high-risk patient should have less than 100. This was 2016, and today 2019 LDLC target values is less than 70 milligram per deciliter. And very high-risk patients, initially in 2016, the value was 70 milligram per deciliter, and in 2019, the ESC guidelines say it should be less than 55. So from low risk of 115 and very high risk, we have 55. EU-wide cross-sectional observational study of lipid-modifying therapy used in secondary and primary care, the Da Vinci study. What does it say? It was a cross-sectional observational study of patients prescribed lipid-lowering drugs for primary or secondary prevention. 18 countries of Europe were involved. Total number of patients was 5,888. Primary prevention, 3,000. Secondary prevention, 2,888. The objective was to evaluate impact of ESC 2019 dyslipidemia management guidelines on LDLC goal achievement. When we follow this guidelines of 2019, what was the LDLC goal? What was the results? What was the impact? Overall, there were 412 patients, the proportion of patients, and we can see that 2016 and 2019, then we have proportion of patients who achieved goal, total 54%, overall 33%, low intensity statin monotherapy 46% and 28%, high intensity statin monotherapy 57% and 37%, acetamib combination 58 and 37%, PCSKI combination 69 and 59%, and other NLTs is lipid-lowering therapy is 28 and 14%. As per the revised guidelines for ECS 2019, 27.2% eligible patients are receiving high-intensity statins. And 33% of the patients are achieving lipid goals with high-intensity statin. So only 33% of the patients with high-intensity statins could achieve their lipid lowering goals. 67% was still left out to achieve their lipid goals. That is it. Now, Da Vinci studies statins using very high risk atherosclerotic cardiovascular disease patients. As per revised guidelines from ESC 2019, in very high risk patients, 37.5% eligible patients were receiving high intensity statins and 18% achieved lipid goals with high intensity statins. That's it. And here we are, 18%. So even after statin, the risk of residual cardiovascular disease is high. The residual risk is still high. And this is to the tune of 60 to 70%, whether it is secondary prevention or primary prevention. The green of this slide shows the residual risk, and the yellow or the orange color shows the risk that has been neutralized by the several trials that I've already mentioned. Now, management of dyslipidemia is at most on priority, and statins are the first line of therapy, as I've already said. And there were two concerns: concern number 1 and concern number 2. Concern number 1 was approximately 60 to 70% of the patients do not achieve their target goals. Now, how do we achieve them? That is the saga. ये तो ठीक है, बहुत बड़ा population है, a huge population who doesn't achieve the goals despite intensive therapy. Then how are we going to do it? How do we achieve the LDLC target after maximum tolerated dose of statin? That is the million-dollar question which I'm trying to answer. Now, the extension of LDLC reduction with non-statin agents. Here, the role of non-statin agents come. Intensity of lipid lowering treatment: moderate intensity statin 30%, high intensity 50%, high intensity statin plus ezetimibe 65%, PCSK inhibitor 60%, PCSK9 inhibitor plus high intensity statin 75%, PCSK inhibitor plus high intensity statin plus ezetimibe. That causes a reduction of LDLC by approximately 85%. Still, 15% is left out. So only moderate intensity statin, the LDLC reduction is 30%. Goal achieved. High intensity, 50%. High intensity plus ezetimibe, 65%. Here, the role of bempedoic acid comes up. It is a new molecule. It was introduced in the European market and the American market in 2020, and has been released for use in India approximately 1 or 2 months back. It is an ATP citrate lyase ACL inhibitor, and it's a first-in-class LDL lowering drug. It is approved in USA, European Union, India, and I've just told that it was released in 2020 in US and EU. And the approved indications are: it is used to reduce uncontrolled LDLC with maximum tolerated statin dose. When you're already using a maximum tolerated statin dose and yet you're not able to achieve LDLC goals, then it is an indication to use bempedoic acid. When there is mixed dyslipidemia, familial hypercholesterolemia, high risk of atherosclerotic cardiovascular disease patients, when there is statin intolerance, or whom statins are contraindicated. These are the indications for use of bempedoic acid. It is available as 180 milligram tablet and can be given with or without food. It's a novel LDLC reducing agent, and the mode of action is it inhibits ACL enzyme upstream of HMG coenzyme A reductase. It acts at a level at the ACL enzyme. It inhibits the ACL enzyme, and its action begins before the action of statins. This we can see, and it is effective in the skeletal muscle, in the liver, in the kidney, and in the skeletal muscle, it acts at the ACLB levels where it reduces the cholesterol. but it also increases, it might cause a slight increase in the uric acid and creatinine, as is shown in the left lower corner of this slide. The pharmacokinetics say that the half-life is approximately 21 hours. Elimination, 70% of the drug is 70% of excretion of the total dose is through the kidney, 5% is excreted through the feces, and 2% is excreted unchanged through the kidney. Now, where you don't need to worry is renal impairment, and no dose adjustment is necessary. No study in ends, but it has not been studied in end-stage renal disease. So you need not give the drug in end-stage renal disease, but mild to moderate renal disease, no adjustment is needed. Similarly, in hepatic impairment, no dose adjustment is necessary, but it has not been studied in patients who have severe hepatic impairment. What needs to be monitored is all patients need to be monitored with their serum uric acid when it is clinically indicated, prior history of gout, increased vigilance for hyperuricemia and gout, and patients who are above 60 years of age taking steroids, fluoroquinolones with renal failure and history of tendon rupture. Warn of potential for tendon rupture and advise patient to rest at first sight of tendinitis or tendon rupture. Where is the need for discontinuing the therapy? Patients who are more than 60 years of age, who are taking steroids, fluoroquinolones with renal failure and a history of tendon rupture. Discontinue if there is a tendon rupture occurs. Consider discontinuing if there is joint pain, swelling, or joint inflammation occurring in any patient using bempedoic acid. This could be due to a raised uric acid. Then taking simvastatin more than 20 milligram or pravastatin more than 40 milligram. Avoid concomitant use with bempedoic acid. Consider lowering dose or switching to other statins. Pregnant, discontinue bempedoic acid unless the benefits of therapy outweigh the potential risk to the fetus. Breastfeeding not recommended during bempedoic acid treatment. Now, what are the bempedoic indications for use of bempedoic acid and phase 3 program? With the maximally tolerated statin background therapy, already using maximally tolerated statins. Then you have the Clear Harmony trial, which was done for 52 weeks. And the total number of patients was 2,230. Atherosclerotic cardiovascular disease in 98%, HeFH 4%, hypertension 79%, and diabetes 29%. Then the Clear Wisdom trial was again for 52 weeks, where 779 patients were studied. Atherosclerotic cardiovascular disease 94%, heterozygous familial and hyperlipidemia was seen in 5%, hypertension 85%, and diabetes in 30%. Then very low or no statin background, we have the Clear Tranquility study and the Clear Serenity study, 12 weeks and 24 weeks with so many number of patients. And atherosclerotic and or HeFH or primary prevention statin intolerant patients were studied. Now, bempedoic acid, Clear Harmony and Clear Wisdom study. The parameters. In Clear Harmony, atherosclerotic cardiovascular disease, HeFH, that is heterozygous familial hyperlipidemia, or both on maximally tolerated statins were studied. And in Clear Wisdom, ASCVD, HeFH, or both or maximally tolerated lipid lowering therapy which may have included no statin or no background lipid lowering therapy. Number of patients were 2,230 in Clear Harmony and 779 Clear Wisdom. Duration was 52 weeks. Percentage of patients on statin was 100%. Efficacy endpoint was LDLc reduction from baseline at 12 weeks. And overall safety was studied at 52 weeks. Now, Clear Harmony and Clear Wisdom. Bempedoic acid persistent hypercholesterolemia despite maximally tolerated statin therapy. LDLC mean percentage change from baseline was approximately 16.5 in placebo corrected difference, and this was approximately 15.1 in clear harmony and clear wisdom. The blue bars are bempedoic acid and the gray bars are placebo. Now, clear tranquility and clear serenity type of patients. In clear tranquility, patients with hypercholesterolemia with statin intolerance, bempedoic acid was added to ezetimibe, and in clear serenity, patients with hypercholesterolemia and statin intolerance, number of patients 269 versus 345, duration 12 weeks, percentage of patients with statin was 32% in clear tranquility and 18% in clear serenity. Efficacy endpoint was LDLC reduction from baseline at 12 weeks and LDLC reduction from baseline at 12 weeks, and overall safety was studied at 12 weeks and 24 weeks. Hypercholesterolemia but unable to tolerate statins was seen in 23.5% of the patients in clear tranquility and 23.6% in clear serenity patients. Phase 3 trial of bempedoic acid or ezetimibe alone or in fixed dose combination versus placebo. Patients at high risk due to atherosclerotic cardiovascular disease or HeFH with LDLC more than 100 or multiple CVD risk factors and LDLC more than 130, all treatments added to stable background maximally tolerated statin therapy and no safety concerns. The clear outcomes and global CVOT. There were 14,000 patients, phase 3 clinical trial. Current status, enrollment is completed. The tentative study of completion data will be December 2020. The results are to come in December 2020. And primary and secondary prevention patients with elevated LDLC and statin intolerance were randomized into bempedoic acid group receiving 180 milligram per day of bempedoic acid, 6,302 patients, and placebo, 6,302 patients. And the study phase was a screening period of 5 weeks, and then single blind placebo run-in for 4 weeks, and then the double blind treatment period evaluating MACE and LDLC reduction of safety. The primary endpoints, effect of bempedoic acid versus placebo on 4 component MACE, that was CV death, non-fatal MI, non-fatal stroke, coronary revascularization, minimum of 1,620 primary 4 component events, treatment for at least 2 years. ADA 2022 mentioned bempedoic acid as lipid lowering agent in high risk patients. Pooled analysis of 4 phase 3 pivotal trials and the adverse events of special interest. Hyperuricemia, the bempedoic group was seen in 1.7 as compared to 0.6 in placebo, and the p-value was 0.007, gout 1.4 and 0.4 in placebo, and ALT and AST increased by more than 3, seen in 0.7 as compared to 0.3, anemia 2.5 versus 1.6, tendon rupture 0.2 versus 0 in placebo, new onset of worsening diabetes 4 as compared to 5.6 in placebo. Tendon rupture was not pre-specified as a TEAE of special interest. In the end, we can summarize as uncontrolled LDLC is a major risk factor for cardiovascular disease. We all agree to this, that whenever the LDLC values are raised, there is risk for the development of cardiovascular disease, and it is one of the major risk factors ahead of smoking, ahead of lack of exercise, ahead of obesity, ahead of tensions and all that. Statin is the first choice of therapy for any type of dyslipidemia. whenever there's dyslipidemia, the first choice of therapy would be statin and is a statin. Even after high intensity statin, more than 70% of the patients have uncontrolled LDLC values. This is a very important fact and a take home message that it's not that you give a statin and feel very good about it, that yes, my patient is on a statin therapy and you have reduced the dose. You have to see whether he's actually achieving his goal or not. It's just like giving an anti-diabetic agent or an anti-hypertensive agent and forgetting to measure his blood pressure regularly or forgetting to measure the blood sugar values regularly, the HbA1cs. And that way you're going to land in trouble. You have to see whether you're actually achieving the goals. That increases the residual CV risk by 60 to 70%. Bempedoic acid is first in class agent having a unique mode of action of ACL inhibition. Significant LDLC reduction up to 18% from baseline as an adjuvant to statin. So the statins can reduce the LDLC to a certain level, then addition of bempedoic acid will increase the reduction by 18% more from the baseline. It is safe in mild to moderate CKD patients. Yes, hyperuricemia and gout are common adverse events which should be monitored on a regular basis. And with this, I come to the end of this talk on bempedoic acid, which is a new molecule that has been introduced for the treatment of dyslipidemia uncontrolled with the maximum tolerated statins and with the mixed dyslipidemia patients, familial hypercholesterolemia patients, high risk of those patients who are high risk of atherosclerotic cardiovascular disease, and those who are statin intolerant or where statins are contraindicated. So thank you very much, Zydus, once again. Thank you, Mr. Kunal Javeri and Vineet and Mr. Priyank Jain. If we can have some questions, I'll try to answer them.
Yeah. Yeah, good. So that was a very wonderful discussion, sir. It was a quite elaborative that you have mentioned that definitely that after high dose of statin, what you are saying that there is a definitely it's a chance that patient having uncontrolled LDLC. Okay. Sorry. Uncontrolled LDLC. So the one of the question is that in your routine practice, in which type of patient would you like to use bempedoic acid?
See, I've just mentioned that more than 60 to 70% of the patients who are given statins, they don't achieve their goals. And this mode of treatment modality where we are running after goals and where we are concerned about the goals has recently been taken up, and we are more concerned with it now. So approximately 50 to 60% of my patients who are getting these statins and not achieving their goals would be needing bempedoic acid. I just mentioned that after giving statins, a very huge percentage of the population, that is 60 to 70%, don't achieve the goals. These are the patients who would need bempedoic acid.
Okay. So, sir, in that case,
kindly unmute yourself. I can't hear you.
Yeah, is it now fine?
Yeah.
So how do you feel that this drug is safe in the routine clinical practice? The data is showing definitely it is safe, but in your routine practice, though it is too early to say, but how do you find that this will be safe?
See, it has been used in the European Union and the United States for the last over 2 years, and we have robust clinical data. Concerns about the adverse events are very, very less, and it can be safely used in patients who have mild to moderate kidney disease, mild to moderate liver disease. Then a bit of concern is there with the uric acid, which can be monitored. and if need be, the dose adjusted, or if there is a precipitation of gout, then even treatment for the gout can be given. So very few patients, about 2 to 3% of the patients would need a discontinuation or stopping of the drug because of severe gout precipitation. Then there were concerns about tendon rupture and tendinitis. Well, it has not been validated too much, but certainly if there are patients who are complaining of tendinitis or pain in the tendons, then one must be cautious in the use of this drug. Otherwise, there are no side effects as such.
Okay, so the last question, sir, I would like to take that in management algorithm by guidelines like AH and European Society of Cardiology, the statin, ezetimibe, PCSK9 inhibitors, they are recommended. Still, Bempedoic acid has not mentioned in the algorithm, but yes, the guideline they have mentioned this is a potential molecule for LDL reduction.
Yes.
So what will be the scope that this drug will be also included in the guideline, whether by ADA, AHA, or ESC, by any Western body?
See, the guidelines come after the molecules arrive and after their use. And when we have seen that it's being used very nicely with good results, and there is robust data which is supporting the use of this drug. And then we have seen that there's a huge volume of patients who are not able to achieve their target goals of LDLc reduction. And there is nothing else to do. You have given the full dose of statins, high intensity statins, you have given them ezetimibe, and still you're not achieving the goals. फिर क्या करेंगे आप? क्या उसको मरने देंगे? You can't let them die like that. And we have seen patients who have been given full doses of statins and along with ezetimibe, and still they are having high levels of LDL and they are having problems. So these are the patients where bempedoic acid will have to be given, and the guidelines will have to include this drug very soon. I think the next guidelines will definitely have this drug on their list, and there is no problem with it.
Certainly. So I think that was a very positively what, sir, you have ended, that definitely this drug will be included in the guideline. And beyond statin, yes, management should not be stopped, and we have to continue, and we have to extend the therapy with a maximum tolerated dose statin along with good molecule like bempedoic acid or ezetimibe.
So at the end, before you close and before you give a thanks, I would tell everybody that the take-home message would be that LDL values, LDLc values are important as a major risk for cardiovascular disease. That is one. Number two, statins are the first line treatment to control LDLc. Full treatment with statins achieve goal only in 30 to 40% of the patients. 60 to 70% of the patients would need additional therapy, which might be in the form of ezetimibe or this newer drug, that is bempedoic acid. Since we have this bempedoic acid, which has very little side effects, very easy to use, single dose, with or without meals, and very affordable also. So this is a very good molecule that has come in the hands of cardiologists and physicians, and we are really very excited about it. And one can safely use this drug in majority of patients to achieve good and to achieve LDLc goals in patients who have cardiovascular disease or who are at a very high risk of developing cardiovascular disease. Thank you very much. Thank you for the patient hearing. And now I hand over to Mr. Kunal Javeri.
No, thank you, sir. I think that was a very elaborative and wonderful discussion. And you ended very positively that, yes, we have to continue the therapy, and students should not be deprived for any kind of such a good molecule, and it has a full rights to having a controlled LDLc as well. So with this, sir, I would like to end the session here. Thanks a lot once again for your valuable discussion and the presentation. Thank you, sir. Thanks a lot. Have a good time. Good night.
Thank you, Doctor. Thanks for the wonderful presentations. It was great to be with you.